video. Great. Please put questions in the chat as I go through this. It's going to be pretty quick. So I want to make sure that if there are things that are unclear, that we are able to address people's needs. So can everyone see my slides? Rachel, we're good? Great. Okay. So as I said last week, shared decision-making is really a model for patient-centered, person-centered counseling and communication that acknowledges that providers have expertise in the different options and the pros and cons, risks and benefits of different options, and patients and people who are coming in to get care are the expertise in what their preferences are, what their needs are, and what will work for them. And so the process of shared decision-making is really designed to bring those two types of expertise together to support the patient to ultimately make the best decision for themselves, recognizing that they are the ultimate person with agency to make the decision. So how do we do that, right? So that is a good general structure for how we think about this, but what does this actually look like? And I will say that in contraceptive counseling, it looks a little bit different than in some. We've done some research on this. We've done audio recordings of contraceptive counseling visits. We've done qualitative interviews with patients. And it is a little different in contraception for a couple of reasons, including how personal and intimate it is. And also because there's just a lot of options. A lot of times in medicine, we're choosing between 2 things or 3 things. And in contraception, we're choosing between a lot more than that. So I'm going to walk you through how the model that we've developed at the person-centered reproductive health program for how to do this shared decision-making specifically in contraceptive counseling. So in order to do this type of sharing of expertise and coming together in a process of shared decision-making, you have to be able to have the patient feel comfortable and feel that their perspectives are valued and their humanity is recognized in the room. So one of the things that we think is absolutely critical is the first moment, the hand on the door moment when you walk in the room. And so even though that's not technically part of shared decision-making, it lays really the foundation for being able to have a person-centered discussion about contraceptive options. And so we actually have done research that has looked into this, like I said, through audio recordings. And what we looked at, there's this concept of the 4 habits, which are the 4 habits of person-centered counseling in general. And the first habit is called investing in the beginning. And investing in the beginning means taking that moment to sit down, look the patient in the eye, greet them warmly, make small talk, etc. And what we found, in fact, that was investing in the beginning was actually associated with contraceptive continuation. And like I said last week, that doesn't mean that continuation is an inherent good, but it does indicate that being person-centered, respecting people, acknowledging them in the room as a whole person is associated with being able to find a method that is a good fit for you, and meaning that engage in a good decision-making process. And so we think this is really critical, again, ethically, but again, to support patients' reproductive decision-making. And many people always, we feel like we always do this. This is something as a provider that we obviously would want to do. And unfortunately, what we found in our research is that oftentimes this is the first thing that goes out the window when we're stressed, when we're busy, all of that. And so, for example, in this audio recording visit we did with wonderful providers who are my colleagues in California, only 2/3 of them greeted the patient warmly. Less than half made any small talk. And I'm talking like, how's your day level of small talk. And then less than half asked any open-ended questions. So we really want to just have this as the starting point for all shared decision-making conversations. So then once you've established that therapeutic relationship, this is the 4 steps that we think of in terms of the process of shared decision-making. One is introducing the conversation, eliciting informed preferences, and I'm going to go through that in some detail, what I mean. This is really that back and forth between patients and providers. Then once we've elicited informed preferences, we provide decision support. And then we talk about after the decision has been made by the patient, we support successful method use, including making it clear that the door is open, the telephone, video call, whatever it might be is open, to ensure that people are aware that they can switch methods and that discontinuation is not a failure. So to walk through each one of these steps, the first one, starting the conversation, what we really advocate for is asking a very open-ended question at the beginning. So asking something like, do you have a sense or do you have an idea of what is important to you about your method? And this is a very, very open-ended question, right? But why do we recommend this as opposed to kind of the more standard things like, what methods have you used before? What are you interested in? Well, we want to make it very clear that we are open to a conversation about patient preferences, that the patient preferences are what matters, and that we're not expecting them to know what they want ahead of time. Like I said last week, there is a real tendency to do what we call foreclosed counseling, which is, what do you want? Okay, here it is. Or what have you used before? Did it work? Great. And just ending the conversation there. And patients are kind of used to that, right? But that doesn't mean that they know about all of their options, right? So we want to open the door for patients to have the conversation that they need to make sure that they are able to make the best decision and the most informed decision. And if someone's coming in and they're like, I absolutely want something that helps my acne, or I absolutely don't want something that's in my body, you're opening the door to that thing right off the bat. A lot of patients will not have an answer to this question, right? This is not the question that often people get asked about anything in medicine, right? It's very open-ended. And so a lot of people will be like, I don't even know what you mean by that. Like, I've used pills before. They'll just ask the question they're being used to ask, right? And that's okay. That doesn't mean that the question isn't valuable. It's actually the fact that they don't answer the question is an indication that you can then support them to find out what is important to them about their method, right? And that your goal is actually to support them in kind of being able to answer that question. So they're not expected to have an answer to it necessarily. And if they don't, that's great. It opens the door to the rest of the conversation. So the rest of the conversation, so I'll get to the rest of the conversation in a second. Some patients, like I said, will answer this question by saying, oh, well, I want pills, or I want the patch, or I want Depo, right? So they'll just answer with the method. And that, again, is okay. Like, whatever the patient brings into the room is okay. But it doesn't necessarily mean that they don't want to or wouldn't benefit from talking about other methods. They may not, for example, know what their options are. And they may think that when you ask that question, what you're actually asking is, what do they want? What method do they want? And they're just feeling like they have to tell you exactly what method they want. So it may, like it says here, it may indicate they know what they want and don't need to receive decision support, or it may mean that they think they're supposed to know what they want to make your job easier. Or it may mean they don't know all their options. So any of those three. So what we really recommend is to start with, great, if that's the method you want and it's safe for you, then absolutely we will give that to you. But if you're interested, we can talk more about your other options just to make sure you know what the full range of options are. So again, asking for permission, asking for consent, opening the door wide so the patients can walk through it to engage with you if they want to, but not forcing them into the decision if this is the method that they know that they want. So if they decline receiving more information, that's when you go straight to method support. Okay, so if they don't have a strong preference for one method, or they do have one but want to actually talk about their other options, that's when you go on to step 2, eliciting preferences. So again, this is different than how many of you may have learned to do contraceptive counseling in the past, which is not like, let me go through all the methods and talk about all the different ways that they vary, right? Because there are so many options in contraception, what we recommend is really starting with taking it from the perspective of the different ways that methods vary without mapping them on to specific methods to start out with, right? So methods vary in a range of different ways. They vary by effectiveness, by side effects, by frequency of using the method, different ways of taking the method, fertility, return, privacy, etc. So what we want to do is understand what's important to patients, so then we can map them onto the methods in the next step to help them identify the best method for them. So it is important to remember that teens and young people who many of you are caring for will have less knowledge overall and experience with counseling. So they won't have engaged as much as, say, your 36-year-old who's had 4 kids will have engaged with the healthcare system in general and specifically about reproduction and contraception, right? So these teens and young adults will probably be less likely to ask questions, less likely to tell you when they need information and decision support, and less aware at baseline of what their options are for what methods are available, especially given what we talked about a lot in terms of the lack of sex education in your geography. So in this context, when you're eliciting preferences, it is incredibly important to really, again, like I said, work on the building rapport, asking probing questions, not making assumptions about what people know, and also being very careful to not be directive in a way that can produce reactance. Okay, so, and when you're listing preferences, it's like I said, it's really important to assume people don't know about their options. So you want to provide context for different characteristics of methods that you're eliciting the preferences for. So for example, saying there are methods you take once a day, once a week, once a month, or even less frequently. Is that something that makes a big difference to you? So again, you're not mapping it onto specific methods. Or in terms of effectiveness, you want to talk about this in the context of the range of different levels of effectiveness for different methods. Effectiveness is something that's very important to people in general. It's just not always the most important or the only important thing about methods, right? But there is often frequent misinformation or misconceptions about the relative effectiveness of methods. So this is a critical thing to provide counseling about without assuming it's going to be the driving factor for method choice. So when we talk about effectiveness, we want to talk about natural frequencies. We want to talk about saying less than 1 in 100 people, sorry, all the gendered languages it's still in here, get pregnant on the IUD, 9 in 100 women. So don't use percentages. People, that's generally higher literacy and more difficult for people to understand. And using visual aids can help. I know I saw that you have some visual aids in your clinic, which is great. It's really using visual aids for contraceptive counseling about effectiveness is good. You just can't have that be the only thing that structures counseling. That can be a tool for counseling people about effectiveness, but not for the entire counseling encounter. For counseling about side effects, I really recommend making sure that you identify and talk about menstrual side effects, because all methods have some effect on menstruation for the most part, other than natural family planning and barrier methods. And that you inquire about, and then after talking about menstrual side effects, if it's important to them, whether they have their period regularly, if they care if they were to not ever have their period, if irregular bleeding would be a big issue for them. After figuring that out, you inquire about other areas of interest. Like, are there other side effects that you're worried about, or other things you've heard about or experienced that you're thinking about when you're choosing your method? And then obviously, this goes without saying, when patients express a concern about side effects, it's so important to respond in a respectful manner, even if we don't think from the evidence that that is a side effect of that particular method. So this is really important, because in our qualitative research, what we found is that people feel like we as providers hide things from them about methods, about side effects. And they don't give you that, we don't give them that information, as this person said, and I don't think any provider has given me that information. So when we're dismissive about side effects, we're feeding into this mistrust, this justified mistrust of whether or not we're giving people all the information they need about their method choice. So if they have concerns about side effects, how can you address this? So for example, my friend said that method made her crazy, which is something that we've heard in our audio recordings. So you could say that's ridiculous. No studies have ever shown psychological effects of this method. Not a person-centered response, right? You don't want to say that. You don't even want to say it without that's ridiculous, right? Instead, one way to say this, I know this, I'm going so fast, I'm sorry, we just don't have a ton of time, would say, that's too bad your friend had that experience. Validate, affirm that patient's experience, person's experience happened, right? Don't dismiss it, because if we dismiss it, the patient's going to not trust us to not dismiss them. I haven't heard of that before, and I can tell you it definitely doesn't happen frequently. So again, giving them evidence-based information, bringing our expertise into the room, but doing it in a way that acknowledges people and their concerns and their experiences. So what about a patient said, if they have a preference for side effects, for example, that's maybe not based on accurate information, saying, I really don't want a period method that makes my period stop. So that could be because patients think that it's unsafe, or it could be because they like having their period every month, even though they know it's not safe. So one thing, for example, that I've heard when I gave a talk to a national conference, somebody stood up and said, well, when people say that to me, I just say, it's really okay not to have your period. Periods on birth control are just a trick anyway. Talking about like that it's a withdrawal bleed, right? It's not a true, like you're not really having ovulation. That is not a trust building statement right there. Patients are not going to feel like they A, understand what you're talking about, or B, that you're actually making them believe in birth control. So instead, what you can say, some people don't like the idea of not having a regular period for a range of reasons, but I do want to make sure you know that it is safe not to have a period when using these methods, in case safety is a concern for you. So again, affirming their experience and their preference, but giving them evidence-based information. So this is the eliciting informed preferences, right? So you're eliciting the preference for not wanting amenorrhea, not wanting a method that doesn't make their period stop, but you're making sure that that preference is based on information that includes that it is safe if you don't have a period on these methods. Equivalently, if someone says, I really don't want to use hormones, I know they're safe, but I want to know what my body's natural cycle is, you could say, well, that really limits your options. Are you sure you want to hear about the hormonal methods? Or you could say, you're right, the hormones and contraception are totally safe to use, but some people don't like the idea of using them, and that's completely okay. Let's talk about hormone-free methods. So that's more of a person-centered response. Okay, so that is we've now done step 1 and step 2. Step 3 is then the shared decision-making process itself, where you actually then, you have elicited their preferences, and now you're mapping them onto method characteristics. So given their preferences, what information about what methods do they need? And you can actively facilitate their decision-making process while not stating opinions that are not based on patient preferences. So I want to give you some concrete examples of this. So I'm hearing you say that avoiding pregnancy is the most important thing to you right now. In that case, you may want to consider either an IUD or implant. Can I tell you more about those methods? So this gets you to the same place that directive tiered effectiveness counseling does, right? Which is just starting with these methods. But you're doing it not based on assumptions about what's important or what should be important to the patient, but you're doing it based on the fact that you've elicited preferences, and this is what the patients told you is the most important. And therefore, it's very clear that you are centering them in their autonomy. So as someone else, you mentioned it's really important to you to not have irregular bleeding. The pill, patch, ring, and copper IUD are good options if you want to hear more about those. So again, mapping it onto methods. So then there's some cases where you'll have more complex cases where it's not, they don't map onto a specific group of methods. I've heard from you that the absolute most important thing is not getting pregnant. And you also want something that makes your period lighter, but keeps it regular. Right? So we know method-wise that all the most important effective methods, IUDs and implants, all change your periods in ways that either make it heavier, the copper ID, or make it irregular and lighter, which is the progestin methods of either the IUD or the implant. So unfortunately, that the methods that are most effective all change your period. So what do you think about this? So naming that their preferences don't map onto one method and letting them decide which of their preferences is the most important. And then, so one thing to think about, and that I've heard when I'm when I'm talking about this, and I've experienced counseling myself, is do you have to elicit all preferences before beginning decision support? Do you have to go through every way that methods vary in that second step? And the short answer to that is no, because some patients will have an overriding preference. They'll say, this is the most important thing to me. Let's just talk about those methods. So you can skip straight to decision support in that case, but you just have to realize that you won't know for sure what patients' other preferences are. So you may end up having to go back to eliciting preferences as you go through the decision support process. So for example, somebody might say, I absolutely don't want something inside my body. So is there anything that will reliably prevent pregnancy that isn't an IUD or an implant, right? So this is a patient who said they really, really want to avoid pregnancy, but then when you tell them about the IUD and the implant, another preference is revealed. And so then you have to go back to the preference elicitation again. And I think this is my last slide, just to consider that some patients will ask for your personal opinion, right? Some patients will say, what do you think is the best method? They're kind of opening the door to more of a directive process. And if that happens, it can be important to pivot to recognize that patients rely on us for our expertise, and just saying I absolutely cannot tell you that because that would be not shared decision making is not necessarily a person-centered approach either. So what I really recommend doing in that situation is responding to the patient's request by naming their preferences, and based on their preferences, what you think the best method is. So based on what I'm hearing from you, this is what I think might be the best method, right? If they haven't told you any preferences yet, saying, well, what the best method is would really depend on your preferences. For example, if X, then Y. So really naming that it is about their preferences. So with that, sorry, Rachel, I went 4 minutes over my allotted time, but I think I did as fast as I could possibly go. With that, I'll hand it back over to Rachel.
Yeah, thank you so much for sharing that. I know we covered these 4 steps. We covered it quickly. Thank you for the examples. Are there any questions, thoughts, comments about shared decision making, things that you might like about it, things that you think may need to be like talked through or worked through? I open up the floor. You can come off of mute, you can raise your hand, or you can place a comment or question in the chat.
Well, we're so interactive in person.
I know it's different, sometimes different energy on Zoom. Okay, so yes,
I might
please.
just, Lisa Sanders, I might just ask a question just because I don't typically do this. So I was just curious when, it's always that tension between trying to do something in 15 or 20 minutes and getting this. So do you find when you're doing this kind of counseling that you're able to do it like in one visit, or do they typically come in and you explain stuff, they think about it and come back? Just curious what the process looks like for you.
That's a great question. Thank you. So yes, a lot of times people are afraid that this is going to mean you're opening the door for this taking a long time. And the reality is that this is doesn't actually usually take much longer, because people usually are pretty able to say what their preferences are, right? A lot of people have an idea. If it's someone like your 15-year-old who's never thought about this, it potentially can take longer, right? And in that case, you may have to think about this as more of a longitudinal process and have them come back, remembering that the goal is not necessarily to get them on the best method for them, or the long-term method for them at that visit. You want to meet their needs at that visit, but you also want to make it clear that you can revisit this conversation in an organized way. Say, okay, why don't I give you these resources, send them to Bedsider, for example, and look at your options and come back in a week and we can talk more about this, right? So I think that it's definitely something that it opens the door to it being some people a shorter process, honestly, than if you go through and just educate about all the methods, and for some people a longer process. And so adapting in the moment to what that looks like is important. But in the longer term, patients will have a better idea of how methods vary in a way that in the longer term, when they come back, it will always be a shorter process. Just the first time, it can be a little bit more unpredictable.
Thanks.
Thank you.
We have time for another comment or question. Okay. If you have something that comes up, please feel free to put it in the chat. We also will take some comments and questions before we end. We're going to go ahead and transition now into our role play activity. So we had some examples in the training, but this is to kind of give you a view of this continuation, where I will play a provider and Christine will play our patient. So to give the group a little bit of context, I'll just read this background aloud. Actually, let me make sure I'm ending. Danielle, is it possible to pin both Christine and me? If not, that's totally fine. We'll figure that out. So an 18-year-old non-binary patient gave birth last year. While they had healthcare coverage for their birth, they got a hormonal intrauterine device during the birth hospitalization. 4 months later, they want the IUD out. They've scheduled a visit to have it removed, and they thought at that visit the provider would remove their IUD. However, the provider did not and told them that they really needed to pick another form of contraception before the provider felt comfortable to remove it, because the reason that the patient gave was not a legitimate reason for removal. So the patient was very frustrated and disheartened that they couldn't get this method removed when they wanted it. And so now they are coming to this youth serving clinic in Big Town, Florida, because they have started a relationship with a new partner. They want STI testing, but they didn't want to return to the clinic that gave them the hassle about IUD removal. So now they're coming to this clinic and they would like to discuss their birth control options, but they're really worried that it will go badly. So, hi Joe, I'm Dr. Ybor. So you want STD testing. Why do you need that?
I just started a new relationship.
Did you already have sex with this person?
Yeah, but before we go further, I want to get tested. I did get tested last year.
That really doesn't matter. You are having sex with someone whose STD status is unknown. In your lifetime, how many partners have you had?
Probably 6.
You've had 6 partners. How many in the last year?
Guess just one.
So you only had one partner in the last year.
Well, I just broke up with them and I'm dating again, so I guess it's 2.
What are you using for contraception?
Right now, I'm using condoms.
That's really not a very effective method for birth control. We're going to try to see if we can get you on something more effective today. There are other IUDs out there, even a non-hormonal one. So as someone with a kid already, you may really want to consider a more effective option than a condom.
So I really don't like having something in my body, and I don't like the side effects.
This could be different, and it likely will be different because you don't know how your body will react if you use a different method. Often patients list a long list of side effects, but IUDs are very well tolerated by most people, and there aren't any known causes of, sorry, they aren't known to cause a lot of issues. I think you really should consider trying the IUD again, but this time keeping it for at least 6 months because you didn't really keep it long enough as we recommend to see how your body reacts.
I really just want STD testing. I don't want to talk anymore about birth control.
That's fine. We'll go ahead with that. However, as you got your IUD removed and you're still refusing another method, I'd like to test you for pregnancy.
Fine.
Okay, so I'll put in the order for pregnancy and STD testing and note that you still refused effective birth control today. We'll contact you if you need anything else. Sorry, we'll contact you if anything comes back positive. Have a good day. Okay, and let's end the scene. So for the group, how do you think the visit went? Yeah, I see some poorly, terrible, not great, super stressful. Yeah, I mean, even as the fake doctor, I was a little stressed with what I was saying. Like, oh my gosh, this is really, really rough. Um, how person-centered do people think the visit was? Okay, so I'm
Do you think
seeing,
these kind of visits actually happen?
yeah.
Not here.
Okay, someone said not here, and another Dr. Adams said, I hope not. Yeah, I mean, I will say the provider did introduce themselves. They probably didn't look the person in the eye, but it felt like after introducing themselves as the provider, things kind of went downhill fairly quickly. Just for a thought, what could help improve the visit? What are some things that you notice of like, I just wish they either said this or had reacted in this way? Anything that comes up for you about what could have improved this visit?
Well, I guess kind of going back to what Christine had said, at least at the beginning, there are the 3 things, maybe some small talk. Besides just introducing yourself, make some small talk. Hi, how you doing? How's your day going? I feel like that would have definitely helped at the beginning.
Yep, agreed. Someone in the chat put the doctor caring about the patient's wants. Yes, that is a key thing. So yeah, they did come in saying, you want this STD testing, but again, once they expressed some other needs or even confusion around kind of maybe the questioning or exhibited discomfort, the provider was not responsive to that. And yeah, just being a little less judgmental about people's sexual histories, all of that is very important. So thank you all. Oh yes, Dr. Weiss.
Well, yeah, I'm here with a couple of residents and we thought that, you want to say what you thought, Grace?
Oh yeah, I thought like it definitely started on the wrong foot where it sounded like the provider was more telling the patient why they were here today instead of asking like, hey, what is most important? Like, what do you want to address at this visit?
And the other thing that bothered me was when the provider was saying like, well, we're going to note that you are refusing an effective method. That really rubbed me the wrong way.
Yeah, so thank you both to Grace and to Dr. Weiss. Yeah, there's an easier way to like just open up the conversation. And then, you know, when people have done chart reviews, like they see notes, right, from previous providers of like refused contraception today or refused LARC. And so thinking about how we support each other and not reinforcing these negative ideas of like, yeah, the patient just preferred, you know, you could put it, patient preferred not to discuss or did not want to discuss this, as opposed to them refusing care or these particular methods. And then Dr. Sanders wrote, affirm them in coming in for STI testing as a positive step for their health. That is excellent. People who experience a lot of barriers and hurdles to accessing care, just appreciating that they even made it through the door, they're there would really go a long way in helping. And then also, Christine put, you know, dismissing the patient's concerns and experiences, and that really interferes with trust in the long term. And the literature definitely shows that, you know, each of these opportunities is just one way that we can help create more relationship building, trust building between patients and providers, the healthcare community, and those that we serve. So let's wipe that horrible experience from our minds and let's see an alternative way that this visit could have gone. Hi, Joe. I'm Dr. Ybor. It's nice to meet you. I think this is the first time that you're at this clinic. We're really glad that you found us. How are you doing today?
Okay, thanks.
Great. So what brings you in?
Well, I just started a new relationship.
That's great. That's great to know. How is it going?
It's okay. Well, actually, it's really great. But I do want to get tested for STIs since you're having sex, and I want to make sure everything is okay.
That sounds great. We can definitely do that today. It's really good that you're being so proactive about being healthy. And is this relationship with someone who makes sperm?
Yeah.
Okay. So how are you thinking about the possibility of pregnancy in this relationship or in general?
Well, I definitely don't want to have another baby now.
That's important to know. Do you want to talk about your birth control options today?
I guess so, yeah, but I really, really don't want anything in my body.
I absolutely understand. That's not an uncommon preference. Is it okay if I ask you some questions about what else is important to you about your birth control so that we can think about what options might work for you?
Sure.
Okay. So I understand that you don't want anything in your body. What else is important to you about your method?
I don't really know.
Okay. I can give you more of a sense of what I mean. For example, one way that methods vary is how you use them. Do you have any preferences about other ways other than having something in your body that you use for birth control? For example, by mouth, on your skin, in your vagina, or a shot?
Oh, I definitely don't want a shot, and I don't do good with daily options, but I think I'd be okay with a pill.
Okay. So I understand that you may be open to pills, having something on your skin, or having a method that you place in your vagina. Let's talk about some other things you may want to consider when choosing your method, like how effective it is and how often you have to think about it. End of scene, because that could open the conversation in a lot of different directions.
Mhm.
What are people's thoughts, or how do you think the visit went? And what made this visit much better or more patient-centered? Active listening. Yeah, we heard the provider repeat back what the patient was saying to them. Some better rapport building, right? Staying neutral, asking questions really good eliciting their preferences, and then didn't force the patient to talk about birth control methods. It really was up to them because they may have come in for something else, in this case, STD testing. And this was just a question, since we know that they are sexually active, asking them. Yeah, and then even asking for permission before offering more information. And so there really is, I mean, as you can kind of see, like these are small steps in a long relationship to build trust with someone. So again, even if the person doesn't leave with a contraceptive method today, what is being demonstrated in employing some of these methods is that this is a good person and this is a resource that I now have. Should I have questions in the future? Should I need future care? So I think those things go a long way. Is there anything else folks would have done to improve this dynamic? Or is there something that you do in your practice that you think could have been incorporated here to improve the dynamic? Okay. Well, seeing none, thank you all for your participation in this activity. I know folks are in different groups, but we're going to do a quick breakout so that you can discuss a few cases, well, actually one case, each group will get one case, and then talk through how you would employ principles of shared decision-making. So I'm going to, I think I can share my file. Oh, perfect. Danielle is already ahead of me. So this is the document you can use. And we're going to split up the different groups.
Like 10 minutes?
Yeah, 10 minutes should be good. And then we'll come back. So be prepared to report back of some considerations, things the group grappled with, and how you would approach each of these discussions. So I will give Danielle a moment for the break. So yeah, if you can, please open the PDF so you can have it. We'll try to also make sure folks have it in their breakout groups. Thank you all for your patience and participation. So Christine, you, Danielle, and me will be floaters, so we can.
Okay, that's what I was gonna ask, yeah.
Yeah, stay in the main room or join a group. I'll let the groups get situated.
Are everybody going to rooms here from here?
I believe so.
Yes, everyone else has been assigned to a room, so they just have to accept, I think, to move.
I
into
see.
the
So
Okay.
Valentina, okay. And then RL Ryan. Okay. And then how do we go between rooms? Let's see.
Oh, I think Danielle has to plop us in one, but we can come back to the main room and get.
Okay.
But yeah.
Well, give him a second to maybe talk.
Yeah, build some rapport before we
Yeah.
infiltrate.
Danielle, how many rooms are there? 2 or 3?
There are 3.
Okay. Thank you.
Mm-hmm.
Yeah, I didn't know who all the providers were on the call, but I at least knew, let's split up Dr. Weiss, Dr. Sanders, and Dr. Adams. So that's kind of what I did to disperse.
Oh, I see. Great.
Them throughout the groups. But I'm sure there are more prescribers.
And then there's it sounds like Dr. Weiss is with residents, so a couple of people not.
Oh, yes. Yeah. So we'll get some additional engagement. Sorry, I
Do
was
we know
not
who
looking at
Arl
the
Ryan
chat.
is?
Yes, that's Reed. I think Reed is in the same room as Dr. Sanders, so she may have just popped in, like joined her
Right, that makes sense.
in her room. Yeah.
Okay.
Okay.
Oh.
Especially after the tech, after the audio issues. Thank you so much, Danielle, for coordinating this.
No problem.
Yeah, I think I can pop into a room in like a listener
Yeah, I'm happy
mode
to
and
too.
see.
Perfect. I'll put you both into separate rooms.
Thank
And then
you.
do you want me to time it for when to bring you back?
Yeah, so probably in the next like 5-6 minutes.
Okay.
Mhm.
Sure.
51.
Mm-hmm.
Okay, perfect.
nice to see all of y'all on camera. A couple more seconds before everyone returns, and then we'll do a quick report out and then close with any questions or comments. I think all the rooms should be closed now, correct? Oh yeah, there we go. All right. I think that's almost everyone. Are we still waiting on for folks? We can go ahead and get started. Who took on case 1? Let's talk about it. Was
We
any?
did.
Oh, great. We have some brave souls.
Yeah, safety in numbers over here. Yeah, do one of you guys want to talk about what we talked about?
There were a few different perspectives discussed. Obviously, wanting to make sure that we were providing patient-centered care and asking about preferences stood out. And then in the specifics of case 1, in regards to being a 14-year-old who didn't want their parents to know, we really wanted to dig into more of why specifically that was, just so we could know how to then proceed. If there's like specific reasons, depending on the specific reasons she would have for not wanting the parents to know would change the way we could proceed next in terms of what we could then suggest or we could let parents know. One option mentioned was if there was an option for just discussing it with the parents in terms of it being for period control and not mentioning anything about potential sexual activity in the future or different things like that that could make it easier on the patient, but obviously centering it around her preferences.
Yeah, got it. So it sounds like you all definitely want to acknowledge the concerns the patient is coming with and then see how you can maybe assist them in getting something that meets their needs while also being mindful of that concern around privacy and confidentiality. And understanding that's a common issue that young people face of like, I just don't want them to know. And I think in terms of some of the method things, we'll send the resource around for the updated chart from Bedsider. But yeah, they have things of like, I don't want other people to know about my contraceptive method. And so that may mean an intrauterine device or an arm implant or something where I wouldn't have to come back to the clinic or go to a pharmacy to get like renewals, which might indicate that I'm taking something regularly for this issue. So thank you for that. Any other comments, Christine?
I would just jump in to say that confidentiality, what the confidential method will be different for different people. Like Depo, we think of as a confidential method, but if it changes your period and your parents are tracking your bleeding, then that's not going to be a confidential method. So finding out what actually will work for them in terms of that confidentiality.
That's a really good point. Yes, because I have heard parents do that. Okay, group or case 2. Can someone share with us some of the things that came up and how they would approach that conversation?
Hi, yes. So basically, we just, we decided to affirm that coming to get STI testing was a good thing, make conversation and I'll make small talk and make an introduction, and then just opening up the conversation and, hey, it sounds like the birth control pill has worked for you before. That's great. Trying to understand, hey, is it a you don't know what you don't know situation, or just if that's the best method that worked for them and if they want to keep doing that. And then from then on, the answers would be, okay, we can discuss more birth control options if you want, or we can just give you the prescription that you need.
Yeah, fair enough. So you're understanding that patient may absolutely know what they already want, but you want to make sure that this really does meet their needs. So creating that opportunity to discuss options further if that interests them, or just writing the prescription for the birth control pill and meeting that need and moving on. So thank you for that. And then case 3, could someone share with us how their group talked about addressing this case?
I guess when it comes to we looked at that case as it pertains to the PrEP patient who wanted to discuss natural options. And I guess first we kind of asked about like their preferences surrounding birth control and what exactly is natural options for the patient themselves, because whether it's like using this barrier contraception qualify as natural, or is it kind of a rhythm method where they're monitoring their periods and probably choosing when to have sex. So those were some of the things we discussed, and also for us recognizing that as physicians and nurse practitioners, that we don't get a whole lot of training in the natural methods, that we probably are more or better counseling about the hormonal contraceptive options. So also providing resources for where they can get more information about it, and also being able to support them if they're having any issues. They can definitely come back and talk to us.
Excellent. Yeah. I mean, that I really appreciate the idea that there's nuance, right? Like we have our thoughts about natural methods, but people may define this in different ways. And so understanding that we are talking about the same the same thing, right? So clarifying that first before providing additional information or resources. And then, saying like, hey, this might not be my expertise, but I'm here to help. And again, keeping that door open to build that trust. So we only have 2 minutes, but in that time, if there are questions or comments, I think we might have a couple more minutes and maybe stay to answer them, or you can put them in the chat and we'll do our best to respond to these. And I think Danielle can help us in sending those out. But any last questions or comments about employing shared decision-making principles?
Okay, I was just going to jump in to say, I think this is one of those, because sometimes with the shared decision making, it's hard as a provider to think where it works. But I really think that these couple of sessions have been very useful, and this is a great situation to use it in. I've thought about the very few times that I've ever had to got stuck in clinic here when a more adept provider like Dr. Weiss or Dr. Adams was not here to do the contraceptive counseling. And this has made me think more about how to do that, and how really coming from the patient-centered approach with this is really, really crucial to do. And if I get stuck in this situation again, I'll be much better at it now, thinking about approaching it this way. But I think this is really an ideal one in medicine to it really tailor the contraception to the person that's coming in for it. So this is it's very useful, this.
Thank you for that. Rachel, should I close us out? Okay. All right. Well, thank you all so much for engaging. I know Zoom is different, so it's great. And thank you for doing the breakout groups and actually choosing all 3 different cases. So that was great. So we're excited to have one more session with you all. Thank you, Rachel, in 2 weeks, and to talk more about team communication and implementing the self-identified need for contraception screening. If you have other things you want us to address, we are happy to be flexible and responsive. So just let us know, or kind of communicate that through Danielle. And we would love to get some questions next time too. So please come with your questions. And we're really grateful to be doing this work in community with you all. So thank you so much.
Take care, everyone.
Thank you.
Thank you.
Bye. See you in 2 weeks.
See you in a couple weeks.